I saw this morning on one of the TV shows, warning, the next 6 to 12 weeks could be the worst so far.
Right.
Is that right?
Probably. Now, San Antonio, maybe not. We're a little behind everywhere else in terms of our cases, and we're at a plateau, which is good. But that plateau is higher than it was in June. So even though we're not increasing extremely rapidly, we are at a starting point that's higher than we were in June, which makes me very nervous. So the rest of the world is seeing a spike. The rest of the country is starting to see a spike. So I suspect we're not far behind.
And hospitalizations are up across Texas and across the country.
They are. San Antonio, they're down. Again, it depends on what you're comparing it to. If you're comparing it to July, we look great. But if you're comparing it to June, it's not so great. And so that's concerning. And I think it's important to keep that in mind. Even though we're better than we were recently, we're getting higher again. Is
it schools opening up and people getting back to restaurants and bars and out?
Well, I think, schools might be a factor. They are taking very significant precautions, and we haven't seen outbreaks linked to schools, but we haven't studied it that closely either. What we really need to do is trace every case in a school and find out, what family, if their households are getting infected, if it's spreading. We haven't really been doing that, so it's hard to know for sure. It's easy to blame the restaurants and bars, and there's a lot of focus on that. A lot of bars have been closed. We've not traced any cases in San Antonio to bars and restaurants. Nationally, there's been a few cases that they have, but we've also traced them to house parties, to weddings, to funerals, to churches, to all those things, as much as we've done to any kind of public space.
Yeah, what is it you think that's driving this right now?
I really think it's family gatherings. I think we have enough data nationally. We saw this across Texas in July when we saw the spike, and I come from a big Mexican family that if you have 10 people over, it's a small crowd. Like it's just us, it's only 10. Like, no, that's a problem. And we tend to think that we're safe because we're with people we know. And so we don't take precautions. We come into our houses, we hug and kiss each other like we normally do, and to not do that is very hard. We take our masks off, we stay indoors, and we are more at risk because of that versus staying outside at the whole time, keeping a distance. It's really hard to do that when you're with family, and it's hard to convince families to change their habits.
What about Thanksgiving and Christmas?
I'm really worried about that. It's a huge problem. So usually with flu, we see an uptick just after Thanksgiving and then a much bigger uptick just after Christmas. And a lot of that has to do with travel, but also family gatherings. And my recommendation to folks is, I know you want to see your family, and I think that's important to do so, but look at ways you can do that in a safer environment. If you can sit outside, we're lucky in Texas, we can do that. Sit outside, keep a distance, don't crowd 10 people around that family dinner table, space everybody out in chairs in your lawn if you can, keep the group small. Instead of having, the 20, 30 family members, keep it to the immediate family, which in some cases is already 20 or 30, but keep it as small as possible, because then you're less likely to have somebody there that's infected.
What about schools? Because around the area, they're everywhere from 15 to 25% to 100%.
Right.
And what do you recommend there?
So I recommend that they stick with all their precautions. They should stick with 6 feet apart inside the rooms. Kids need to wear their masks at all times. Masks are a great help. They're not enough. You need that distance as well. And it's going to be concerning with crowded hallways, moving back and forth. Northeast just opened up to 100%. They still have virtual option, and that's where my daughter is today for the first time. So we'll see how it goes. But they have strict rules about how the kids can walk in the hallway. They can't crowd. They have to stay to one side. Like following lanes. Those things will help. It remains to be seen how much of a risk factor that is.
How long are we going to be wearing masks and distancing and things like that?
Until we have a vaccine that everybody can get. It's going to be a while.
But will everyone take it? Is that one of the things you're worried about?
So I'm not going to worry about that yet. Right now, I want to make sure we get a vaccine. No, not everybody will take it. We know that. I worked in vaccines for the last 6 years. We know people refuse vaccines. There's a lot of skepticism. It's frustrating for me right now that we're focusing so much on the vaccine hesitancy and that it's being pushed through, I think, in an unsafe way, because public health is built on public trust. And if there's any doubt about the safety of the vaccine, people aren't going to take it, understandably so. And so we need to make sure it's extremely safe. It's better to be 2 months later and be sure that your safety protocols are in place than to rush something through and then have it not just fail, but be unsafe.
We're heading into flu season. How big a problem is that? Or because we're socially distanced and we're wearing masks, is it going to be less?
Well, that's what we're hoping. It depends on how good the vaccine is. I haven't seen data yet to see if more people are taking the vaccine. Certainly more people are talking about the flu vaccine. Right. It's usually hard to get people to take it. This year it seems like more people are, but I haven't seen data to verify that yet. So if more people are vaccinated, if the flu vaccine works, and we add in all the precautions we're taking for COVID, which work for flu, we might have less flu this year, which would be great, because normally flu season, our hospitals fill up. We get close to capacity, and if we add COVID on top of that, we're going to be in trouble.
Now you kind of back up now, and you worked at the Yale, or you went to the Yale School of Medicine?
School of Public Health.
Public Health?
Right.
And now how did you get to San Antonio? And you've been here for a while.
Right. So I did a master's in public health. I'm originally from California.
I can tell. You got a little California accent.
I could never get that out of me. I went to Yale School of Public Health for my master's degree in public health and epidemiology. And then I started a PhD there and ended up moving to Notre Dame to finish my PhD, and that was in tropical diseases. So I had studied tropical diseases all those years. I came to San Antonio actually to live in Thailand. So I had wanted to study malaria. I had been studying the mosquitoes, and now I wanted to study the parasite. And it used to be the Southwest Foundation for Biomed Research. Now it's TBRI. They had a job to study malaria parasites in Thailand, but based here in San Antonio. So I was a postdoc. So I came here for that, but I spent most of that time in Thailand. I'd go back and forth. I spent about 6 months there and then come back here for a few months to work in the lab and then go back. And then it was 2001. It was actually September 10th, 2001 that I started my job.
Wow.
So I'll never forget that date. And on one of my trips back, my husband, who was not my husband at the time, happened to have recently arrived from Switzerland. We met and decided to stay here. And here we are 20 years later.
And now you've worked for Metro Health?
Yes. So after I finished that postdoc with Texas Biomed, I worked briefly at the USDA, and then an opportunity came up at Metro Health for epidemiology position, which I had been doing research for a lot of years, but I started in epidemiology. So it was a great opportunity to go back into my roots of epidemiology, and I started there. And that was, it was the year Katrina happened. And so I kind of got thrown into shelter management, things I never thought I would do. And then as that was winding down, Dr. Guetta said, he was the director at the time, said, "Who's our pandemic flu expert?" And I said, "Cherise." Like, what? I had not worked on flu before that, but I had to learn everything there was about pandemics.
So there was no pandemic expert before that, really?
No, and it was really, it was a national movement at the time. And if you look back through that era, President Bush was very focused on the potential for a flu pandemic, and we were worried about the bird flu at the time, which it's not transmissible between humans, so that's why it's not a pandemic potential. But that's what was our worry, and so he actually motivated a lot of investment in pandemic planning at the time, and nationally and actually internationally, there was a large focus on pandemic planning in sort of 2005 to maybe 2008 or so.
But then since then, I saw an article the other day that Texas spends about a quarter to a third of what some states do on public health.
Oh yeah, yeah. It's just gone down every year. It goes down. Texas, that's not a focus. Public health is seen as something for poor people, or it's not a money generator, it's not important. But as we see now, it's preparing and having the systems in place, having that infrastructure in place is essential.
And that's one of those things now in terms of the state and reporting and testing that has been so I don't want to say chaotic, but confusing, because some people were faxing in and sending in paper reports, and there's still no mandate to do it in one way.
So I laugh because I keep saying faxing, is it like 1995? What the heck? But that's still the system in a lot of places, because faxing is thought to be more secure. Now, we can do electronic transfer that's secure, but you have to set the systems up to do that. And it's really hard in governmental systems to change. It's much easier just to keep doing what you're doing instead of progressing electronically. When I worked at the state in 2009, 2010, I was using a 10-year-old computer. It was crazy. Eventually got new ones. But a lot of that money came from Homeland Security for pandemic planning, and also the preparedness money. That's where our systems were able to upgrade, was because of that. But then that money started to go away over the years.
And then since then, we had SARS 1 in, what was that,
2003.
And then in 2009, H1N1.
Right.
What was that like here?
So that was an interesting time. I was the communicable disease manager for Region 8, which includes Guadalupe County and 28 counties surrounding the area. And we had the first case. It was actually, the person lived in Guadalupe County, so it was part of our region, was identified at Randolph Air Force Base.
And you talk about first case, it was the
first case identified worldwide. Eventually we found there were earlier cases. When we started to look back and backtrack, we found earlier cases elsewhere, but the first one identified. And I remember it very clearly because I was actually getting on a plane that day to visit my mom for her 75th birthday. And I got a text saying from the state epidemiologist that it was actually two cases. We found a novel flu virus. It looks like swine flu. This might be something big, or it might be nothing at all. I think, oh no, this is big. And sure enough, within a few days, it was clear that this was going to be something different and big. It's a very different response to now, because flu, we were prepared to deal with a flu pandemic. We knew what we were dealing with. We knew more or less how the virus acted. Even though it was a novel strain, we knew what to expect. We were able to invite the CDC in immediately to come help us and set up the planning and do all the contact tracing and help us with all of that. So because we started it here and it started small, it was almost much easier to manage. But there's a lot of resistance to even talking about it. There was a lot of politics and pushback of like, don't say that we have this because it was right before Fiesta and we don't want to talk about it and it's really not a big deal. And we didn't know at the time, is it going to be like 1918 or is it going to be like one of the smaller pandemics?
And flu's different than this, but the SARS in 2002, that's the same family as COVID, right?
Right.
Because there's other COVIDs.
Right, so there's other coronaviruses, and SARS is a specific type of coronavirus, and this is basically called SARS-2 virus, SARS-CoV-2, which is a long name. It's very frustrating. Very similar type of virus, but with SARS-1, it was very, very deadly. It was more transmissible, so higher rate of transmission, but it also made you sick very quickly and very sick. So you were not likely to transmit it because if you're that sick, you're not going anywhere. So the death rate was higher, but it stopped relatively quickly. A lot of control measures were put in place, very extreme measures, which helped that, but also the fact that we didn't have much asymptomatic or mild transmission, and so it didn't transmit the way we're seeing with COVID now.
And now, I remember seeing an interview with you in May, but a lot of things have changed since then, and we've learned a lot. What are some of the things we've learned about COVID since then?
Aerosolization is one. Now, it's still very unclear. We're still working that out. But so the virus is transmitted by droplets. We know that to be true. And that's how flu is transmitted. To be truly aerosolized transmission, it's like measles, where it lives in the air for long periods of time. What we think is happening with COVID is that it's still droplet transmitted primarily, but it can hang out in the air for a little while. And that's why indoor environments are problematic.
But the masks keep the droplets from...
the masks are really helpful. They keep the droplets from going. Now, the virus can still pass through the cloth masks, but it's not spreading the same way. It's not spreading rapidly in the air, so that if you're wearing the mask, you're at least preventing yourself from the droplets coming out. That's why we say it's more about protecting others than you, because you might breathe it in still, but you're less likely to droplet it out.
In the pandemic of 1918, everybody wore a mask. Well, there were sewing
some
masks,
of the same
and
issues,
it was
yeah.
a lot of. I've seen pictures
Right.
of police officers wearing masks. Sewing circles here in San Antonio made them. Did we not know to do that right away, or do we worry about the shortage of masks?
We worried about the shortage of masks, and if you see interviews with me from February, I said don't wear a mask, and that's because mostly we need the best masks are the N95. Those are the ones that are truly protective, and that's what healthcare workers use. And there's a shortage. They're just not enough, and they need to be reserved for the healthcare workers. And the other thing is masks give us a bit of a false sense of protection. If you're not a healthcare worker, you're not used to wearing it all the time, you fiddle with it, you take it on and off, you're not wearing it properly, it's not going to be fit tested properly. I remember being in the grocery store and a woman had on an N95 and she had pulled it down, and so it was like the top part of it was inside her mouth as she was holding, as she was like paying and doing something, and that's just the worst of all worlds. And so it's almost better to not wear one, because you want to make sure there's enough available, and most people aren't going to wear them right. Over time, we realized, hey, the cloth masks are actually making a difference, and we don't have N95s available for everybody, so let's get everyone to wear cloth masks.
I remember my daughter is a nurse and worked with some COVID patients, and this is in Houston where they had a lot, and there was concern that they didn't have the N95 mask then, and so they wanted to keep, the masks for them. But since then, a lot of people have decided, well, I don't need a mask, and you tell them you need a mask.
Right. That's the issue. So what your daughter experienced is absolutely true. We needed to save them for healthcare workers, but they need to be available for everybody. We need to make sure that we're wearing them as much as possible. People also think, well, it's outside I'm less worried because the virus dissipates in the air. Inside, though, people will say, well, if I'm 6 feet away, then I don't need the mask. Well, no, you still need it because the virus might be hanging around, and you wear a mask.
What do you think when you see people in bars and young people, or the so-called super spreader event at the White House?
That's very frustrating. So the White House situation is interesting because that's a political statement not to wear a mask. They had the Rose Garden event outdoors, which helps, but everybody was packed in close together, because even outdoors you should have some space. They were all packed in close together, and then they had an event inside as well. And they weren't wearing masks, they're hugging each other, they're in really close contact. In places like bars and restaurants, it's a little different because generally your group is small. So because of the guidelines we have, the bars aren't packed with people standing everywhere. They're confined to a table. That's the only time they can have their mask off. And so essentially you're only exposed to the people that you came with. And you're presuming that those people that you came with sitting at your table are the same people you're going to socialize with anywhere. They might be at your house. They might be riding in your car. So you're at risk to each other, but not necessarily everybody else in the room.
This week, bars open up again in Texas, 50% capacity. Restaurants expand to 75% capacity, a lot of other businesses as well. Do you worry that's going to change things?
I'm not too worried if the businesses follow the guidelines, and most of them have. I've worked with some of the restaurants and bars looking at their spacing. It's not just capacity, but it's having tables 6 feet apart and not pulling groups together and keeping those groups small. So the ones I've worked with have been very diligent about making sure their staff are following all the rules, that their spacing on tables are appropriate. And some of them have gotten a lot of hassle from customers who refuse to wear masks, and they say, look, we're going to get fined unless you do this, and they get attacked and they get bad Yelp reviews and all that, but they're sticking to their guns. So as long as the restaurants and bars do that, I'm not too worried. I'm actually more worried about those 5 people that are gathering at the bar. I'm worried about their pre-party at their house or their post-party at their house, because that's where there's nobody reminding them to wear a mask when you get off the table. There's no structure in place, and also people tend to drink more when they're at home. They will pour stronger drinks because there's no limit. If you go to bar, technically they're supposed to pour at a certain level.
I was a bartender, I know that.
Okay, yeah. So, you're supposed to. Not everyone does.
Yes.
You're supposed to. But at home, there's no regulation for that, so people tend to drink more. At least that's what TAB CDC says, and I'll trust them. And so people take more risks when they're in their comfort zone of their home. So that's actually what I'm worried about more. And then you have families in the same home, so multi-generational. So the 20-year-olds or the teenagers may not get sick, but they get infected and they can transmit it and they give it to their grandparents or their parents.
What about asymptomatic spreading? Now we have community labs that just formed here, and they want to test everybody because of the asymptomatic spread.
I am so thrilled about that because we have not been testing asymptomatics for a while now, and I think that's critical because we're estimating 40 to 50% of infected people can be asymptomatic. Now, there's asymptomatic and pre-symptomatic. Pre-symptomatic means you're just not sick yet, but you're going to get sick. Asymptomatic means you never show any symptoms. But COVID can be pretty mild. So I might cough, and I think that because I'm about to cough, as soon as I say that, I'm going to have to cough. Excuse me, that always happens.
Okay.
If I say the word cough, I'm going to cough.
But that doesn't necessarily mean, and how about the pre-symptomatic? How many days can you be infectious before you actually get
typically
symptoms?
It's 48 hours before symptoms occur that you can be infectious, but you might not realize you actually have symptoms because, like I say, you have a cough, but you cough all the time, so you don't, and it's mild, it's not that significant. Or you have a headache, but you have headaches once in a while and it's not that big of a deal, so you'd say, oh, I don't really have symptoms, but actually you do, and that's more likely. Now, probably if you're truly asymptomatic, you never show any signs whatsoever, the risk of transmission is fairly low. It's maybe less than 5%. But if you're pre-symptomatic, it's going to be more like 40%. That's what we found in various studies.
And now, young people, asymptomatic, spreaders, likely to go to bars more, very much unlike the pandemic, the flu in 1918, when it really hit young people the hardest. And this is one of those things that you can't, I mean, I guess technically the cytokine storm that if you have a good immune system, it can attack that. In this case, it doesn't. But this is one of those things you'll learn about it that who knew?
Right. It's, it's interesting, the similarities and the differences from the 1918 pandemic. But yeah, you're right. Younger people tend not to get as sick. And they're the ones that are out and about. And so I'd actually argue if we have a vaccine, we should give it to the young people because it prevents them from spreading it to higher risk people. If you are elderly and confined in your home, you're not likely to get exposed except to maybe your child or your grandchild. And if they're protected, they're less likely to give it to you. Now, that's not usually how it ends up working, but that would make sense. Because young people are less likely to get sick, they're more likely to go out and do things and not realize that they're infected.
What about testing and tracing? How are we doing with that?
That's been a challenge. If you look at the number of tests we're performing, we're far down from where we were this summer. And
is that because people aren't having the symptoms?
It's a combination of things. I think we have fewer cases, so people aren't getting as sick, so they're not going in for testing. I think also people are just discouraged from testing. The testing hours are very short. It's harder to get tested. It's difficult to go somewhere to get tested, just the timing and all to make it happen. And up until recently, if you were asymptomatic, you couldn't get tested. And so testing numbers dropped, but also I think there are less cases out, so that goes together.
And some young people that I've talked to who had COVID, their doctors say they had COVID, they hadn't tested yet for COVID, but they didn't want them to test. It's like, we know you have it, just go stay home. So the numbers might be lower than what the actual release numbers are.
Right. And that's, if it's a handful of people, that's not that big of a deal, but it is important for us to know that you have it so that we can monitor it appropriately. And the contact tracing is critical. So the city won't contact trace if you don't have a lab report. So even if your doctor says this is a COVID case, I consider it a COVID case, and you submit that to the city, it's not considered a case for their purposes for counting, and they don't trace it. So that person, unless the doctors work with them, and usually the doctor's not going to identify all their contacts and notify them, then they might have already exposed a number of people who won't know about it.
But now you say pre-symptomatic was, say, 48 hours. At the White House event, it was on the weekend, and then you had people first get it or show symptoms Wednesday, Thursday, Friday, Saturday. So this is, 4 or 5 days.
Right. Well, you're infectious 2 days before your symptoms occur. Somebody there was infectious on that day. incubation period, so the time from when you get infected to when you get sick, is usually about 5 days, 5 to 8 days.
But
for
the first
most
three,
people.
you're not infectious or so because the
The
virus.
virus
isn't-
hasn't replicated enough. You don't have enough virus in you. Now, that's not 100%. You can be infectious from day 2, but typically it takes a few days for that to happen.
And now Metro Health and the reaction and their response there. How has that gone? Because you used to work with Metro Health. I'm sure you watched that. You felt
I
for
watch it
everybody.
very closely. Because I know what they're going through. I've been there. I think in May when we set up the COVID response coalition, that was a huge thing because it allowed the people from the community to help Metro Health and doing the planning and saying, okay, really, you need to step up. We need to make sure we have all these mechanisms in place to be able to respond to a surge. And so we're getting there. I think we were not prepared in June for the surge that happened. But now they've contracted with UT School of Public Health to do contact tracing and case investigation, which has made a huge difference.
But contact tracing, if you don't show symptoms even for 3, 4, 5 days, people say, I have no idea where I got it. So how do you trace it?
So there's two parts of contact tracing. There's the retrospective. You go back to try to find out where you got it, and forward to prevent people from spreading it. So let's start with forward. So I want to know who you were with 2 days prior to when you got symptoms, or at least when you had your test, up till now.
Because I could have spread it to them,
could have
not
spread it to them.
necessarily that I got it from them.
Right, that you could have given it to them. So say I turn up positive in 2 days. I know, sorry, I don't know my mask back on. They'll say, okay, who were you around? I'll say Randy Beamer. Like, okay, then you get a call that's going to say, they're not going to say Cherise exposed you. They're going to say you were potentially exposed. So you need to monitor for symptoms. You should get tested on this day. You should quarantine for X number of days. That's to stop the spread moving forward. Going backwards, we look back 14 days because that incubation period could be as long as 14 days. And we want to know where you've been, who you've been with.
Before you show symptoms.
Before you show symptoms, right. Most people do within 5 to 8, but it could be as long as 14. So we use that whole 14-day period. We're not necessarily going to identify where you got it or from whom, but what we're looking for are clusters. If we find that 5 people show up on the same day with having been to one location all at the same time, okay, something's going on that location. Or maybe those 5 cases are all related. And they may not know they're related because they were with other people. But we find out because we've investigated, like, okay, that person, they all knew John Smith. Mm-hmm. Let's go find John Smith because he might be the source of it. Or it might be a church picnic, or it might be, a party. That's how, when you see the studies at the wedding in Maine and a few other things, it was because they did this back tracing, the retrospective tracing, to find out where it started. They may not know who was the first, the index case, but they'll know, okay, that's the cluster. And that's important because that helps us prevent the spread. It helps us identify hotspots. So if you think about it like a fire, there's 2 things. You want to stop that fire from spreading, and you want to keep looking for those hotspots so that you can see, okay, this might turn into a big inferno. We need to stop it now.
And so those people should be tested even if they don't have symptoms because they could be asymptomatic spreaders.
They could be, right. You're not going to test everybody. It's just not practical. But of those people that you identified in the 14 days prior, you'll look at if there's any connection to anybody else. If you have 2 cases or 3 cases that are connected to one individual, yeah, you're going to test them.
Now, I've seen across the state where some of the smaller towns, Amarillo, Lubbock, are having the worst. El Paso now, they're worried about hospital space.
Right.
Why do you think that is?
I think there's fewer control measures, maybe. Like, we were really looking at it in the cities, and people in rural communities weren't thinking that it was much of a problem because they're not in crowded spaces. And so they maybe weren't taking the precautions. And again, family gatherings, community events, those things are spreading events. And then you add that into less hospital capacity in a small town, and you quickly overflow. And we saw that in the Rio Grande Valley this summer.
And the mask waivers that some of the county judges are asking for, even if they
Right.
have, I think they have to have fewer than 30 cases. Mm-hmm. Is that a good idea, or?
I understand why, it does vary from place to place. I mean, if you're truly rural and, there's Riel County, which has more cows than people,
Right.
I get it. But those people are still gathering at a church you have potential for infection. I don't know if Kerr County has a mask mandate, but I was there recently and nobody was wearing masks. So there was a town event and we were driving through, but we saw all these people without masks. And so even though they may not have that many cases now, all you need is one person to spread it. So I do think that masks should be compulsory everywhere.
I was down on the Riverwalk, Alamo Plaza. I've been down once a week since July when there was no one downtown, and there were a whole lot of people downtown on Friday, which is great for tourists, great for business. A lot of people who are watching this say, great, it's wonderful, and then some people who watch it say, I can't believe that. Why are you down there? Those people should go home.
Right.
What would you say when you see business like that?
I think that, again, the businesses need to be taking proper precautions, and if they are, and encouraging people to keep distance, those are good things. Businesses need to survive. Unless we're going to support businesses otherwise to stay closed, which we're not, then we need them to survive. That's for our entire economy, but just, for our community's sake. Like, it's hard to restart a business once it's been closed.
And a lot of people are wearing masks, and if you go past somebody, say on the Riverwalk, it's tight.
It's tight, but you're not standing there talking to them. If you're just passing someone, the likelihood of getting exposed and you're wearing a mask is going to be extremely small.
Is it really 15 minutes that you have to be close to somebody?
It's 15 minutes isn't a magical time period. You could be there 13 minutes, you can be there 18 minutes. It's just, that's where we know, like, the likelihood of somebody transmitting after 15 minutes is much higher than it is before. Because again, if you're just passing, it's not a problem. Now, a few months ago, back in May, actually, I met with the Riverwalk Association, and they were trying to get the city to help them to make the Riverwalk one way. So on once you had to go in circles. And the city said they didn't have the resources to do that. But that was something the businesses were trying to encourage, because the businesses, they don't want to show up on CNN as the center of an outbreak, but they need to be open to function. And so they are following the guidelines as best they can, but they can't control everything that happens outside their business.
Well, they look like they're coming back, which I guess that's encouraging. People getting out. Does it also show signs of pandemic fatigue?
Absolutely. Yeah, we're social creatures. We can't stay isolated forever. We need to get out. We need to be among people. Even the most introverted people need other people around. And we have to give people the tools to do that safely. If we liken it to abstinence. If we say, not at all, don't interact, that's not going to work. People are going to do it anyway. So we say, okay, you can interact, but this is how you do it. Wear a mask, stay 6 feet apart.
How about sports?
Sports are more challenging because you can't stay 6 feet apart. Contact sports are problematic. Schools are playing football, and occasionally there's a case and they have to shut the whole thing down. I've worked with some schools and we talk about that weekly. I was like, are we ready to go to in-person game, actually do games? What we talked about at first was the schools doing, instead of practices, doing more skills training so that they can do those separately. They don't have to crowd into each other, but now that they're playing games, it's going to be problematic.
Now, you worked for a while recently for the immunization project?
Partnership.
And that's to get people, to convince them to get vaccines and immunizations.
Right.
You know how tough that is.
Yes.
How much tougher is it going to be for this? I know that's one of the things you don't want to worry about right now, but... Right,
and when I say don't want to worry about it, I think because we're spending so much time talking about vaccine hesitancy that it's making people think, oh, should I be hesitant? Let's rephrase how we talk about it. And also there's just a lot of distrust, which is valid. They're pushing a vaccine through, usually vaccines take years to develop. They're pushing it through really fast. Now, I think it's going to be easier than some vaccines, but I understand the level of uncertainty. And so people are going to be hesitant to take the vaccine that is not tested sufficiently to feel safe about it. Now, I'll take the first one that comes, because that's me, because I'm willing to take that. But I may not tell my elderly mom to do that, because I want to make sure it's safe before she does it. It's going to be a problem, not just a general distrust of government, but there's a long-standing history, particularly in the Black community, of distrust of public health. You're probably familiar with the Tuskegee syphilis study, which went on for decades, and that it ended in the 70s, but it's still brought up as a reason to distrust public health. And then you add in our situation with racism in across the country right now, that I've seen, I've been part of a lot of the Black Lives Matter movement and Facebook groups, and I've seen posts saying you can't trust the government, they're going to give this to us, it's going to be bad. And we have a lot of work to do to try to convince folks to trust us. And they're not going to trust me, an Hispanic woman, coming to tell them that you should trust the government. They're only going to trust one of their own. So we need to make sure that we're getting the right voices involved in those conversations. And we have to be trustworthy ourselves. And the way to build trust is to be completely transparent and honest with everything.
Well, now minorities are affected by this much higher here in San Antonio as well. Is it because there are underlying health reasons? Is it because of economic factors?
So economic factors drive the underlying health issues. If you see the map of San Antonio, if you live on the south side, your life expectancy is 20 years shorter than on the north side. It's crazy. And if you look at where heart disease, obesity, and access to care are problematic, it's all the south, west, and east sides, whereas the north side, it's very different. And so the economic factors, lack of health insurance, lack of access to care, drive a lot of those things, as well as sort of the access to grocery stores and healthy foods and all of those things. And if if you've got hypertension and you manage it, you can be okay. But if you don't have a doctor because you don't have health insurance, which is the economic factor, it's going to spiral out of control.
And for a while there, people were saying, oh, they had underlying health conditions, so it's not really the virus that killed them.
It's still the virus.
Everybody has underlying, not everybody, but what, 30, 50% of the population has some kind of underlying health condition.
Exactly. And if you look in San Antonio, certain parts of the city have even higher rates of underlying health conditions. Certainly if you're healthy young adult, the likelihood of you needing hospitalization is much smaller than if you are a 65-year-old with diabetes that's unmanaged. Absolutely. Because all of the issues are going to be a factor there. But we also see healthy young adults dying too. And it's not just about death. It's about complications of it. It's also just about debilitation. Being sick for 2 weeks is not good. And if it requires your hospitalization, even if you're more likely to survive, that's still using the resources of the medical community, which is an issue. You're taking a hospital bed, but also you might have long-term consequences. And we're seeing heart problems and lung problems of people that have had COVID who were otherwise young and healthy.
Long haulers. That's one of the things we're learning about. And there's some odd effects of this. Have you seen these kind of effects, neural effects from other diseases like this?
Right. So measles is an interesting one. We don't see measles very much now, fortunately, because we have a vaccine. But measles infection can lead to death 5 or 6 years later. Because of the way it impacts the immune system, you might recover initially, but it causes other complications, and it causes a neurologic disease and other things that it's very rare. I'm not trying to imply it's a common thing, but we do know it happens. And so it's out there. It's a lot of illnesses can lead to longer term complications. So
is that one of the things you have to be worried about down the road with this?
Exactly. And we don't know what's going to happen with COVID. We don't have experience with it. With SARS, the death rate was so high that there weren't a lot of survivors, and you really need, a lot of these things are rare enough that you need a large population to start to see it and start to understand it. Sorry, mosquitoes are probably
getting you. It's all right.
I'm getting bitten by mosquitoes too.
It's not malaria here, is it?
No okay. Malaria. I don't think we've got West Nile right now. So the long-term complications are going to be problematic, and we just don't have enough data yet to know how problematic those are.
Looking at Europe and the surge there right now, I don't know how you describe, was there a first wave, a second wave? I've heard people say now we're in a third wave. Not that it really matters, but why do you think it's coming back in Europe?
Well, they relaxed control measures. They did really aggressive control measures at first, which really worked, and then pulled back. Now, it's normal for it to happen in waves. We knew the waves were going to happen. It's just a matter of how big those waves are. And if you pull back complete control measures, then it takes a while to build up, and then it builds up steam, and then you're really up there. My husband's family's in Switzerland, so they were really hit hard at first. And then this summer, they were all showing us their photos of going out and doing things together. And I was so jealous because we were in the throes of it here. And now they're getting hit really hard again.
People might think they have immunity. There's a lot of talk about herd immunity. What if you could describe that to people, what it's supposed to be and how far away are we from that?
The only times we've been able to have herd immunity is with vaccines, and really only smallpox. Measles, we've gotten close, but we're not quite there because a lot of people choose not to vaccinate. Herd immunity means that there's enough people in the population that are immune that if one person gets infected, they're not going to give it to anybody around them because all those people are immune. But you have an infection rate, we're still only like 2 to 3% in most parts of the country. That's not herd immunity. Herd immunity depends on the virus, but it needs to be upwards of 70%. With measles, it needs to be 95%.
And how many people need to get the virus or get that shot
Well, right.
before there's something like that?
So we don't know for sure. I've heard different estimates. A few months ago, I was hearing 85-90%. Now I've heard more like 60 to 70% might be okay. So I'm going to say at least 60% need to either get infected and be immune or get the vaccine and be immune.
Now, there's Dr. Scott Atlas, one of the White House advisors, who disagrees with Fauci and Birx and a lot of them, and has talked about herd immunity. Do you worry about that? He's not an epidemiologist.
I worry a lot, and if you Twitter is the source for epidemiology and medical information right now. It's been great to follow a bunch of scientists there, but absolutely I worry about that because it's not natural herd immunity. We've never used that as a mechanism for disease control.
To just let people get the virus so that many people have it, that there will only be a few that don't.
Well, and one of the reasons that we've been able to control the death rate is because we have enough healthcare resources to serve those people. But what happens is if you get too many people sick at once and too many people needing hospitalization, you don't have the resources to treat them. So that death rate goes up, as well as all the heart attacks and strokes and all those other things that still need hospitalization. You don't have the resources for because you're focused on COVID. And so death rates of everything go up. So if you're relying on that without controlling the infection rate, you're going to see even more deaths. You're going to see a bigger problem.
How about therapeutics now? When President Trump got sick and we heard about Regeneron's monoclonal antibodies and that there were others, people think, well, we're getting close to at least a cure or treatments.
They're treatments. I don't know that they call them cures necessarily. We're getting there, and if we get some decent therapeutics, that could be a game changer. It doesn't mean that it's okay to get infected, but it does mean that we can control it a lot better. And already, like they know how to manage the disease a little bit better. So they have fewer people in ICU, for example, whereas before most patients were going to ICU. Now it's fewer. So that's helpful. If we get more therapeutics that are effective, that will be great. They're still all in the experimental stage, though.
Is it easier for older people to get it because they need less of a viral load, or is just their immunity is less?
As you get older, your immunity is not as good. You usually have other health complications, which might seem minor, but as we get older, our bodies are not in as great shape. But, I have a relative who's 90 who just had it and was briefly hospitalized and is now home and doing well. And we actually, in San Antonio, we had 5 cases in people over 100 early on, and I believe they all recovered.
Wow.
So that was pretty amazing.
But the way it's raced through some places, like the nursing home on the southeast side, and you had a number of deaths, but there was like 100 or something like that, dozens of people. It doesn't seem like all of them would have been together that close for that time.
No, but in a nursing home, there'll be a staff member that goes through multiple rooms. So maybe the residents don't interact, but the staff member interacts with all of them. If there weren't necessary control measures in place, and this was in April April 1st when they had that, so there probably weren't in strict control measures. Their interaction, you're interacting with one other person, and that person interacts with one other person, and they interact with 1 or 2 other people, and that's how it spreads. So it's not just one person sharing it with everybody, or everybody getting infected at the same time. It's usually over a number of days.
Are there good things that are going to come out of this? Say people realize the importance of public health. People want to be epidemiologists. People want to maybe spend more on pandemic planning.
All of the above. Most people know what epidemiology means now. 20 years ago, they thought it was skin diseases, and now everybody's right. Everybody knows about epidemiology, which is great. I think that there's a new understanding of the importance of prevention in public health, that we need to put resources into preparing. It doesn't mean that you need to have 500 people on staff ready to respond to a pandemic, but you have have a baseline of people trained, and you've identified the resources to go to. And that's what we did in 2005 in our pandemic planning. We had, okay, who are all the people on our staff that we're going to call upon in the first phase of like the first 2 weeks? And then what resources are we connected to train those folks to step in, because we can't use our staff the whole time. So being prepared for that and doing regular training, regular exercises to get people ready for that, that's going to be really important.
I understand that COVID viruses mutate less than flu viruses. Is that true, or
yeah,
are we finding out that's not true?
Well, no, mutation is probably the wrong word. So all viruses mutate when they copy themselves. Most of those mutations don't mean anything. They don't provide an advantage. They're just there. Now, it might sweep through the population, but it's just that one happens to be the one that's transmitted. Flu virus is a segmented virus. I love this stuff.
Okay.
So there's different components of the virus. And when you get two flu viruses together, when it's copying itself, those segments mix up. It reassorts. That's how you get a whole new strain. And so that's the danger with flu, because you get a new strain every few years, or sometimes you get a completely new strain that's really deadly. The other thing that it does is more rapidly is called anagenic drift. So the surface of the virus has certain proteins on it that are infection. That's the thing that goes to the cell. This is what happened a few years ago. We had the right strain in the vaccine, but there was anagenic shift. So that antigen, that protein, changed just enough that the antibodies your body produced to the vaccine didn't recognize that protein. Even though the virus didn't actually mutate, the antigen just shifted enough to change. That doesn't seem to happen with COVID, with the SARS virus.
So is that going to make it easier to get a vaccine that's effective?
I think so, right. I think that with flu vaccine, we have to get a new vaccine every year because there's different strains out there. COVID or SARS-CoV-2 appears to be just like one major strain, and even though there's a few strains out there, the antigenic surface, which is what the vaccine is looking for, it doesn't seem to be different enough to warrant needing a different vaccine.
How about different ways to treat it? Are we coming up with different ways? Because the monoclonal antibodies is one thing, remdesivir is another.
They're looking at a lot of different ways, and I tell you, I haven't done the research on that, so I don't get too much into it other than seeing some news articles. Everybody is looking at different ways to treat it because there's different things that happen too. What's crazy about this virus is that it infects so many symptoms. We thought of it as just a respiratory virus infecting the lungs and the nasal passages, but in fact it's affecting the heart pretty significantly. It could infect other cells in the body, and so they're looking at therapeutics that are addressing different things, because you might be the one that has a heart problem from it, and another person might be the one that has a lung problem from it.
And I talked to a pediatric cardiologist a few months ago who said they were seeing more kids with the heart problems that mimic other kinds of heart problems from the disease. I can't think of what they call that, but I'm seeing, I mean, that's one of the things you have to worry about with kids, and not just say, oh, they're fine.
Right, exactly. You know, kids don't seem to get as sick, which is great, but the ones that do tend to get very, very sick. And it's interesting that they're more often seeing the heart problems in kids than in young adults, for example.
How long is it going to take for us to get widespread asymptomatic testing here that's really going to make a difference?
Oh, that's a tough one. So the reason we have the asymptomatic testing is because Graham Weston was committed to it and convinced the city to do it and said, I'm going to make sure it's paid for. But they still have limited capacity. And so they're going to have to ramp up their capacity, which means, you know, his pockets are only so deep.
Right, they're already asking for money.
Right, he's going to need resources to expand upon that, to do more asymptomatic testing.
But supposedly that could be a model for the rest of the country, the rest of the state at least, but because this is a different test than the rapid test, which has the false negatives. This says the PCR test, you have it.
Right, exactly. So the rapid test is an antigen test, which works pretty well if you're symptomatic. If you're asymptomatic, it's hard to say because you get the false negatives, as you said. So the PCR is great. It's still 24-hour turnaround. The reason it's faster, because usually the PCR is longer, is just because they have the capacity for a limited number to do quickly like that. And that's why they started it in Somerset ISD, which is fairly small. They're going to have to really ramp up lab capacity. PCR itself doesn't take that long to do. It's a few hours typically. I've run a million PCRs in my life, but to do that many all the time, you really need a lot of lab capacity to do it. And so they were able to do it because they started fairly small. But to ramp up to the level that's needed, we have to build labs with capacity to do it. That's going to be hard.
And now, how about what people call, I guess, antibody testing? Say people want to know, well, I was sick back,
Right.
months ago. Maybe I have the antibodies and I'm not going to get it.
Right.
But
So-
those tests, are they
The tests
reliable?
they're not very reliable. I think I haven't, the studies on them haven't been very good. So I don't want to say they're not reliable, but I would not rely on them myself to determine, if I had a positive antibody test, I'm not going to say, okay, I'm not at risk. Even people that have recovered from confirmed COVID, we recommend they still wear masks. Probably it's not an issue. Probably they're protected. It's part of it's just good behavior in the community because it's a sign saying I already had COVID. I don't need a mask. It's good to wear it. But the antibody testing is it's not good enough yet to feel confident of it. To say that if I have antibodies, I'm not contagious and I'm not going to get it.
But I've talked to people who said, I know I don't have it because I was sick.
Right. Well.
You shouldn't act that way.
You shouldn't act that way. You need. I was very sick in February. I had traveled to California and Florida within about 10 days, and I came back very sick, all like flu-like symptoms, COVID-like symptoms. I got tested for flu and I was negative. About a week later, I tested positive for strep, even though the symptoms actually weren't like strep. But they did give me antibiotics. I got a little bit better, but it went on for 3 to 4 weeks. And maybe I had it. I haven't actually done the antibody testing. Maybe not. Nobody in my household got sick, so I'm assuming that I didn't have COVID or they would have gotten sick too. But I wouldn't rely on that as confidence that I'm not going to get it.
Is there pneumonia coming out of this like there is flu?
Yeah. So definitely COVID pneumonia is a common thing.
And if people out there say these numbers are inflated, you've seen that on Twitter.
Yeah.
There are, I don't want to say conspiracy theorists, but there are people that are going to listen to this and say, why are you scaring people? It's not that bad.
The numbers are likely undercounts. They're not overcounts. There's a lot of people not getting tested, as we talked about earlier. So yesterday the city reported, I think, 2,500 backlogged cases. So they'll go into the numbers somewhere, but right now they're not counted. So there's 2,500 cases not counted yet, and I'm not sure how they're going to, if they're going to do it by the lab report or exactly how they're going to do it, but it's not in there yet. So that's already 25 that are not being counted. They give it in the overall total, but not the distribution. And then that's the case across the state. It's the case across the country. And those are for actual lab tests. So you think of all the people that are not getting tested because they're pre-symptomatic or mild symptoms, or because their doctor says you have it. Don't bother getting tested. So the numbers are undercounts. I have no doubt they're undercounts. Back in February, March, I talked a lot about not being scared, being confident, let's manage this. We're going to be okay. We don't need to panic yet. And I don't want people to panic, but I want us to be very concerned and pay attention. I remember I had people afraid to go outside. They were afraid, and I still know people that are living in fear. And I don't think we need to live in fear. I think we need to understand what we're dealing with. And saying we have, the millions of cases that we do, that's not meant to be fear-inducing. That's meant to be factual evidence.
How about being reinfected? We've seen a couple of reports now of people being reinfected. Right. Is that another thing you don't usually see or you didn't expect to see?
Well, I didn't expect to see it, and you don't usually see it. And, most not all. So the reason that you usually get, you get a cold 10 times a year, it's a different virus each time. Different kinds of viruses cause colds, and there's differences in the virus that will reinfect you because it needs to be exactly the same. That's why flu also changes. So usually it's actually a different virus. With COVID, it looks like it's the same virus. It's still very rare. So we've had, I think, 2 cases in the U.S. and maybe 2 or 3 worldwide of all the millions of cases that we've had. The rate is extremely low. Now, is it more common than we realize? Possibly. I think probably not. You're always going to have the 1 or 2 outliers.
How about deaths? That's another thing we hear from people. His deaths are all inflated. They didn't die from COVID. They died from diabetes. They died from this. They died from that underlying cause instead of COVID.
Well, the underlying cause sped up the death. If they didn't have the underlying cause, they might have survived the COVID. So those things work together. But if they didn't have COVID, they may not have died. Diabetes isn't a death sentence. If you can manage it, you can stay pretty healthy and live a very long, healthy life. But COVID on top of diabetes can be hugely problematic because it exacerbates the problems.
Anything else I haven't asked you about that you want to tell people? Do this, don't do that.
I would say don't be afraid to socialize. Socialize responsibly. Be conscientious about your environment. Ask people, if you're going to see friends, ask them where they've been, what they've done. Have that conversation. I work in HIV now. It's a lot like what we do for HIV. You want to have a conversation with people. Like, have you been going out? Okay, you say your mom is elderly, high risk, and you take care of her. Like, okay, I can't be with you at this event with 20 people, but if you want to get together one-on-one and sit outside in my backyard, we can do that. So have those conversations and don't be afraid of those conversations. The other thing is we do have a tendency to shame and blame, and that's not helping anybody. If you get COVID, you're not a bad person. You didn't do anything wrong. I'm not going to blame you. I'm not going to shame you. Tell us where you've been so we can make sure that we prevent the spread. It's just like HIV. We deal with that same thing. Shaming and blame actually hurts health department. We can't trace.
How about mask shaming when people don't wear masks?
So again,
or encouraging people to wear masks.
Encourage people to wear masks and encourage them to wear properly over their nose. I hate seeing them underneath the nose. When I see someone wearing it wrong, I sometimes tell them. It kind of depends on the situation. Rather than shaming, because that just makes people angry, talk about why it's important. Mm-hmm. Like I'm not going to say you're a bad person for not wearing your mask, but here's why I wear a mask, because I'm protecting you from this virus. So I would recommend, if you're not going to wear a mask, then you need to be over there and not sit with me.
But if you had that conversation with some people, they're going to be offended.
They are, and that's so. It depends.
Even the conversation about where have you been, especially.
Right. Well, and what I would ask for people is to not be offended by that. It's not accusatory. And that's where you have to not bring the shame into it. I'm not going to shame you because you went out to 5 bars. Like, okay.
Well, you should. And I didn't, but.
You say you did, and okay, but were you taking all the precautions? And were you with different people at each? So if you were with 5 people here and 5 people there and 5 people there, okay, you've been exposed to too many. So we're not going to be I'm not going to be in a small room with you. We might meet outside. And it's,
And you just lost that person as a friend.
Maybe. But you also have to recognize like how important it is for you to make sure that you're not going to get infected and give it to somebody else that's high risk. And that's why I say, like, if we're on the receiving end of that, so if you're somebody who's not going to wear a mask and you're somebody who's going out to parties all the time, recognize what you're doing and how that's going to impact those around you and take those other precautions.
How about shopping as we get ready to go to Christmas and Thanksgiving and things like that?
So stores need to do what they've been doing before, which is limit the number of people in the store so they don't get crowded. I'm not too worried about just shopping because, again, the virus doesn't live that long in the air. It's not like you pass somebody briefly, but if you've got a crowd in an aisle for 10 minutes, then you're going to be exposed to each other. And so the shops are going to have to start limiting the number of people.
And now you work for the San Antonio AIDS Foundation?
Mm-hmm.
And give a plug for that, because people may have forgotten there is HIV out there, and there are people that are long-term affected by that.
Right. So HIV is a disease where we are able to manage it fairly well, and it's really important to get tested early and into treatment early so that you can manage it and not spread it. One of the challenges with COVID is that it's been more difficult for us to test. So usually we go out to bars and universities and all to do testing to identify people early on, but we haven't been able to do that. And also people are afraid to come in to get testing. So we do offer testing at our Grayson Street offices. We're doing drive-up testing, which has been great. We're bringing our numbers up testing again, but it's still a little hard for us to do the outreach testing. HIV is still there. And despite our quarantine and social isolation, people are still interacting, and we have HIV, we as well as all the other STIs are out there. So it's going to be important to make sure you're taking all the appropriate precautions for HIV and other STIs as well as getting tested. So call us if you want to get tested.
Has COVID done anything to cut the spread of anything, aside from colds, maybe flu.
You know, it's probably affected other respiratory viruses because we're taking all these precautions. The data are not very strong out there to tell us, like, oh, you know, the rate of this is going down, the rate of that's going down. I think there was a downturn for a little while. We know, for example, the rate of DUIs has gone down. So probably the rate of car accidents went down for a little while. Right. But there's other factors there at play, too. For diseases like HIV, what's gone down is the rate of testing. So we actually don't know if it's impacting the virus at all.
Some people who say, well, this many people die from flu all the time, we should pay attention to flu, and why are we paying such attention to this?
Well, we should pay attention to flu. But with flu, we have a vaccine and we have treatment. And the treatment's not great, and you need to get it within a couple days of getting sick, but we do have it. With COVID, we have neither of those things. And so that's what's scary. Once we have a vaccine and once we have treatment, we will probably treat it like flu.
Are we treating flu a little too blasé because it mostly affects and kills older people?
Right. I think that's very common. Flu, a lot of people think they have flu when they don't really have it because they feel under the weather. But if you have flu, if you really have it, I've had it twice in my life, you know you have flu. You can't get out of bed. You're absolutely miserable. Your body aches all over. It's horrible. And so most people don't realize that. And so they think they have flu. And so they think it's not that big of a deal. And again, deaths typically happen in the very old and very young. Now, H1N1, it was the young adult population and the teenage population that was impacted the most, and pregnant women, actually, that were dying from that. So flu varies. In the 1918 one as well, it was young adults that were the most sick. And that has to do with immunity to similar viruses.
And now the flu vaccine, they kind of have to guess, as I understand it, which strain is going to be prevalent, and sometimes the vaccine's more effective than others. Same this year?
Right, so it's an educated guess based on what's circulating in Asia the year prior. Sometimes it's spot on and sometimes it's not at all. Don't know yet this year. So far it's looking like what's circulating is related to what's in the vaccine, and the vaccine seems to be effective, but we won't really know for a couple more months to see, you know, if there's any changes.
But now's the time to get vaccinated for the flu.
Get vaccinated for the flu now. Don't wait. Get it now.
And get the vaccine when it comes out for COVID.
Get the vaccine when it comes out for COVID. Now, it's not going to be available to everybody at first. It's going to be a targeted population. So make sure those targeted populations get it, and when it's available for you, get the vaccine.
Well, thank you very much for your time.
Thank you.
Really appreciate it. Give her a hand. Thank you very much. Appreciate it.
Thanks for coming.